welcome to Health Talk. I'm your host, Angela Baracco-Eddy. With me tonight is Dr. Rick Newman. He is a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. You can find him at the Endoscopy Center on Davis Highway. And there's some other offices, various places that he practices as well. Tonight we're going to be talking about fecal incontinence. It's a topic that not a lot of people talk about very often, but it is something that is somewhat prevalent. So we're going to be talking about that in some detail this evening. We're live this Wednesday night, so if you have a question or a comment for Dr. Newman, give us a call. We would love to get that question on the air. If you aren't comfortable sharing your question on the air, call us anyway, and they will take your question off the air and bring it to us during a break so we can still have your question answered by Dr. Newman. Again, tonight's topic is fecal incontinence. It will be on the screen throughout the program, and they will have the number on the screen throughout the program as well. The number is 1-850-972-2642. That is a local number for those of you that are in town, 850-972-2642. Feel free to give us a call. We would love to hear from you if you have something that you'd like to either ask or share about fecal incontinence. And of course, it's always good to begin with the very, very basics, even before we get to the definition of fecal incontinence. Dr. Newman, let's start with the definition of what is gastroenterology. We'll start there.
So, first of all, thanks for having me back.
Absolutely. It's great to see you again.
Thank you. Good to see you too. So, gastroenterology is the specialty that studies the gastrointestinal tract, which starts at the mouth and ends at the other end that we're going to talk about tonight. But it also includes the liver and the pancreas, frequently overlooked as part of the gastrointestinal tract. So, esophagus, stomach, small intestine, colon, liver, pancreas.
Awesome.
And all the diseases thereof.
And there's a lot, and we talk about them all throughout different programs, but tonight we're going to focus specifically on fecal incontinence. So tell us first what the definition is, and of course then what particular area of the gastrointestinal tract that's going to affect the most.
So the definition of fecal incontinence is the lack of control of passing either solid feces, liquid feces, or air. Not having control of that is the definition of fecal incontinence. Some people will call the inability to control the passage of gas or air anal incontinence, but some of that is just semantics. But it's basically the inability to have control over that fairly basic bodily function that most people take for granted, quite frankly, until it goes wrong. Until something's not working properly, then of course things change.
So what specific areas, it's not just a muscle necessarily that's causing the problem?
It's not, it's complicated. I like to use the analogy, for example, when you look to the camera, for example, and if I keep my head still and I look to the camera, my eyes move in perfect sync. They end at the exact same spot, and that is an extremely complicated process that involves muscles, the nerves, and the brain. And we take it for granted. And when it doesn't work perfectly, and your eyes do not land at the same position, you see two of everything, right, called diplopia. So there are a lot of things that we take for granted that are actually very complex with a whole bunch of things going on behind the scenes. And the same is true with the function of that part of the GI tract, specifically the rectum. And am I allowed to say anus on television?
Are. I think
is
that's
that okay?
Okay,
Okay,
yeah.
all right. So the rectum.
I think the actual physical terms are
it
good.
It is. No, it's we use it all the
not.
time. I just wanted to be sure.
No, I think you're
good.
But
okay, so but that part of the body is also very complicated with respect to the feedback from nerves from that area to the brain. Because if you think about it, as you may have had the occasion, you're sitting there and you think, I feel like I have to pass gas. I apologize. First of all, I have to apologize to the audience I didn't pick this topic, okay?
It's a good topic, and it's something.
I actually wanted to be a rock star when I grew up, and here I am, talking. Right.
Who knew? Who knew? Me too. Who knew? But it's a good topic because it's a little bit uncomfortable to talk about, but it's something that a lot of people probably want to know more about? If you're having problems in this area, it's probably not something that you're comfortable saying, hey,
Yeah.
you know, this is an issue with me. So it's good that we're talking about it and
Exactly.
we're letting people know it's okay.
There are a lot of things and problems that we see in the office that people don't talk about at cocktail parties and social gatherings. I mean, it's the nature of a lot of specialties, but in our specialty,
Medicine in general.
and people at first feel a little bit uncomfortable, but in my world, we talk about this stuff all day long. We talk about it at the dinner table, for that matter. So we're pretty comfortable talking about these things. But it's an area of the human body. So here you are sitting in public, and you get the sensation, or maybe even in private, that you may have to pass gas. Your brain will say, wait a second, that's not gas. There's something there. You don't want to relax the sphincter and let it go because you're going to have an accident. So there's sensation that occurs that's just as important as the function of the valve down there that we call the anal sphincter. So it's a very complex interplay between the nerves down there, the nerves in the spinal cord, what's called the parasympathetic and sympathetic nervous system, and also the brain. And so again, it's one of those things that's extremely complicated. We take it for granted, but if it's not working properly, it causes a whole bunch of disability, just like your eye is not landing at the same place when they're supposed to.
So let's break that down a little bit. There's a lot of things there. There's muscles, there's nerves, there's brain communication.
Correct.
All of those things. So any of those things could be the problem.
Exactly. You're exactly right. So for example, somebody who has had a spinal cord injury. So you take that out of the picture, and that person obviously has a problem, both with defecation as well as controlling things. If you have a person who's extremely demented, if anybody has had the opportunity of taking care of a loved one who has severe dementia, when the brain is not working properly, they have a problem along those lines. If you have a person who has had, for example, radiation therapy for a man with prostate cancer or a woman with ovarian cancer, for example, it changes the muscle of the rectum itself and sometimes the anus, and they can have a problem controlling things. So there are, in fact, a lot of different causes, but that being said, the net effect is the same thing, right? You know, the experience that all those people have is the same thing, which is unwanted accidents, if you will, sometimes large volume, sometimes not. And then more subtly, which some people listening at home are probably going to think, I experienced this and I've never really thought about it as fecal incontinence, but you really shouldn't be leaking anything. So leaking a little bit is also incontinence. If you talk to most people that are most people that are young and healthy, say somebody between the age of 15 and 35, and you ask them how often do they experience that, it's not very often. Now, as you go up in age by decades, you find that it becomes more and more prevalent. But even something as much as leaking a small amount can lead to some disability. Maybe not as much as having a frank accident, but I call it having accidents and leaking. And both of those are considered to be episodes of incontinence, if you will.
At what point, since that's not something that's common, at what point should someone seek medical attention if they are having concerns about leaking or accidents?
Yeah, that's a really good question. You know, first of all, I guess I'd have to say nobody's really died of fecal incontinence, right? So you have to put it into a different category than somebody who's having chest pain. You know, if you asked me, when should somebody seek medical advice for chest pain or a problem swallowing, if you want to stay in the GI world, there are life-threatening things that can inhibit swallowing. But when you're talking about fecal incontinence, other than the rare case where somebody may have a rectal cancer or an anal cancer, you know, Farrah Fawcett died of anal cancer. Other than that, which those conditions usually present with other problems, they can present with fecal incontinence, but by and large, I think it's a fair statement to say that most people are not going to die from fecal incontinence. So the answer to your question is when it's getting in the way of their life, okay? And getting back to a very small amount of leaking, that may be having itching or burning. Some people think that they have hemorrhoids, and in fact, it's not hemorrhoids at all. They're actually leaking a little bit. So it's one of those symptoms. The answer to your question again is it's when it's bothering you enough that you feel like it's getting in the way of your living. Now, at the other extreme, There are patients that I have, that we all have, that won't leave the house hardly. I mean, I call it the ball and chain disease. There are some people that won't leave the house. And when they do, they wear Depends, they put pads inside the Depends. So it can be really disabling. So it spans a spectrum, but it depends upon who you are and what you do and what point in your life is in terms of how bothersome it is to you.
But there are treatment options available.
There are treatment options, but you know, we were talking a little bit earlier before the show. This is one of those symptoms that that we don't like very much, because historically we have not had a lot of good options for therapy. You know, there are certain things that in our specialty, like a lot of specialties, that we find very rewarding because we've really nailed it. When somebody walks in the door and they have a certain set of symptoms or a condition, we smile, because we know that that person is going to be happy virtually 100% of the time, and the solution is going to be easy. This is not one of those, and it tends to be something that we don't even like getting into very much, because we haven't had a lot to offer historically.
And there's a lot of different things that could cause it, so it's probably a lot of research into it to find out. We do
an evaluation. We do an evaluation, and if you want to limit at least this part of the conversation to an adult and not a child with fecal incontinence, you know, we want to know that things are correct anatomically, for example. And so we will almost always, for example, take a look at the rectum, take a look at the anus, usually with a colonoscope. Sometimes we'll do a sigmoidoscopy. Again, it depends upon the age. And make sure that the anatomy and the lining of the GI tract looks good. We also do a routine physical examination. We also, with a physical examination, test the function of the sphincter muscle. Is it strong? Can the person squeeze? Can they relax? Now, we have some sophisticated tests that actually measure that by using a probe, if you will, that's hooked up to a computer. So we can really get some of the tests we do, I probably shouldn't talk about on television, but we can really nail down the anatomy, the physiology, the pathophysiology, meaning what's not working properly, and any problems with anatomy. So we have a lot of technology that we have to try to narrow things down. It's an interesting problem, though, because if you make a list of probably the 5 to 10 most common causes of this, what's interesting is that by and large, the treatment for all of those people is going to be very similar.
Interesting.
Most of the time. There are exceptions to that, but most of the time the treatment is gonna remain fairly similar for these different conditions.
Interesting. We've had a call come in, so I want to make sure that we get to the caller. Hello, and thank you for calling. Do you have a question or a comment for Dr. Newman?
Yes, thanks for taking my call. I wanted to see if there was a relationship between taking antibiotics and having this fecal incontinence. I had the flu in January, and they put me on the antibiotic, and at night in bed, I had some leakage, and you know, it was in my pajamas and that type of thing, and so it was a little bit disconcerting, that type of thing. So I was just wondering if there was a relationship. After I got off the antibiotics, I no longer had the problem. So I just wondered if that's something you could talk about, and I'll listen. Thank you.
Thank you very much for your call.
Yeah, that's a good question. So you're bringing up a good point, and that is that, as you can imagine, somebody who is constipated would probably not have as much difficulty as somebody who has a problem with diarrhea. So having fecal incontinence and a diarrhea problem, which antibiotics very commonly cause some diarrhea, and it may be that it's just enough to tip a person over the edge so that it becomes problematic. And I suspect with the caller, if they're still on the line, that after you finish the course of antibiotics and that illness resolved, you probably didn't have any more episodes of fecal incontinence. But having diarrhea of any cause on top of having a problem down there with dysfunction will exacerbate the problem and make it more difficult. And in fact, getting back to your question as to what are the different options for therapy, Probably the thing that we've been doing the most for decades is we deliberately try to constipate the person. I like to say we drive them towards the cliff of constipation without going over, which is difficult sometimes.
Sure.
You know, I mean, it's complicated physiology, it's complicated anatomy, and we're going to have you put something in your mouth, whether it be a pill or a powder or a liquid, that's supposed to make everything function like it did when you were 16 years old. Doesn't quite work that way, but yet that still remains in large part a mainstay of conservative therapy, is to try to get the person as constipated as possible without causing constipation.
Wow. We're going to take a break. It's time for our very first break. We've got a lot more to talk about. Stay with us. We'll be back in just a minute with more Health Talk.
Our weight. It's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
Has anyone ever said, you're the picture of health? You look healthy, you feel fine, but that may not be the full picture. Colorectal cancer is the second leading cancer killer of men and women over 50. It doesn't always cause symptoms, but it can be prevented. Screening can find precancerous polyps, so they can be removed before they turn into cancer. Get screened. Make sure you are the picture of health.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Rick Newman. He's a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. You can find him at the Endoscopy Center on Davis Highway here in Pensacola. And tonight we are live. Our topic this evening is fecal incontinence. It's a new one, something we haven't talked about on the air before. And it might be because it's sometimes a little uncomfortable to talk about, but we've had some questions, and some people have called. We've had at least one caller. We've had a couple other people who have called that haven't wanted to be on the air and ask their question, but they've still had some good questions. So during the break, they brought us a couple of these questions, and I want to get to that because I think, again, it's a very good question and some things that people might be uncomfortable talking about, but other people might also have the same question. So it's good that we can answer it on the air. So one of the callers called in and said that he has a history of acid reflux, and he said that he had the wrap procedure done, which we can talk about in a minute too. He had the wrap procedure done. It has been many years. It has since come undone. But he said an hour or so after eating now, he feels like he has to go. He said it comes on kind of like gangbusters. He has got to go to the bathroom immediately, and if he doesn't make it, then he could have an accident. And he wanted to know, could that be related to the acid reflux or to the wrap procedure? He said he also has diverticulosis, so could that be also a contributing factor? So we have a few different things in there that could be contributing. Dr. Newman, what do you think?
Well, thanks for the question. It's a really good question, actually. So, first of all, what you've had done in the past may or may not have anything to do, but it's possible that it does actually. When a person has surgery for acid reflux, we sometimes call it a wrap, or a Nissen fundoplication is actually, but we call it a wrap because we take the stomach and actually wrap it around the bottom of the esophagus to prevent acid reflux. There can be damage to the vagus nerve, and the vagus nerve is a nerve that travels down along both sides of the esophagus, and then it spreads out all throughout the entire GI tract. And having damage to the vagus nerve can actually cause some symptoms related to bowel function. So it's a little bit of a stretch, but it's possible that it's contributing to the problem. But I think the way to think about this question is the fact that this person says that they eat and then they have to run to the bathroom. And if they don't get there fast enough, they have an accident. We call that fecal urgency, okay, which can lead to fecal incontinence. And actually, when we talk about fecal incontinence, one of the first questions that we ask the patient, are you having what we call urge incontinence or what we call passive incontinence? Now, urge incontinence is where the person has a warning and they can sense something's going to happen, but they just can't get to the bathroom fast enough. Sometimes it's a matter of there's no way you could make it to the bathroom. Other times it's because you're in the middle of Sam's and it's just too far. So it can either be minutes or it can be seconds. Those are examples of what we call urge incontinence, and that's what this person has. Passive incontinence is the person is just sitting there and all of a sudden they're wet down there. Right, there's not a lot of warning. So this problem where the person has fecal urgency, we deal with very, very commonly in our specialty, in our practice. Now, not everybody with fecal urgency actually has accidents. Okay, but again, it's the same story as the person that called in that had diarrhea for a brief period of time that then developed incontinence. This person has fecal urgency that also has incontinence. So in this person, we may treat the fecal urgency, and we have medications for that. And if we can get the fecal urgency under control, maybe they won't have any fecal incontinence. So yeah, I mean, it's a good question.
So again, it's the treatment option.
And it's medication. It's medication, and it's a medication thing. Most of the time we're going to use medication, but if you like, we can talk about some of the other things that we use.
Let's go ahead and do that.
For this problem. Yeah. One of the interesting things is there's biofeedback that can be done, okay? And again, this is not the most pleasant thing to talk about, but what's done with biofeedback, and an example of biofeedback with respect to things that we typically don't have control over, if you take a person and you hook them up to an EKG so they can see their heart they can see their heart beating on the screen, they can see that as they breathe, their heart rate may pick up and pick down, and they can actually get to the point where they can control their heart rate. And that's an example of biofeedback where you see it and then your brain can control things that normally we're not trying to control. So we do the same thing in terms of trying to control the function of the anal sphincter. And it's done by a specialized physical therapist that does biofeedback in this area. And there's actually one group in Mobile, Alabama, and there's a group in Crestview of all places. We don't have anybody right now in Pensacola that does this. So people are sent to those two locations, and they actually put a little device inside the anal sphincter. The person actually looks at a computer, and when they squeeze, they see the pressure go up, and they hold it, and they watch it go down, and they can actually train themselves to do it without thinking much about it. So that's one of the interesting things that can be done for fecal incontinence is biofeedback. That's
great. So it's actually strengthening the muscle.
It is.
That's great.
It is. And there's actually two parts of the anal sphincter. There's an internal and an external. The external is the one that if you sit here and try to squeeze right now as we're talking, that's the one you have control over. But the internal anal sphincter, we don't typically have control over it. But with that device, you can actually learn to control it. It's interesting. And another type of treatment, there's a test that we do at the Endoscopy Center called an endoscopic ultrasound. Women that have had babies that had a very bad tear during childbirth, the tear can actually extend into the anal sphincter. And with an ultrasound probe, we can see the tear. And in those people, sometimes there are surgeons that will go in and actually fix the tear. So there's an example of surgery that's done. Okay. Another operation that's done is they've actually taken part of the muscle near your buttocks, if you will, in your leg, and bring it up and recreate a sphincter. And since it's a muscle that we can control, and through biofeedback, it actually, so there are some things that are interesting. The problem is they've been doing that for a while, and the surgeons don't like doing them very much. They end up not working very often, and they don't last very long is the problem. They're not enthusiastic about doing those things. One of the new things that has come along is a device that we use where we put a little probe in the nerve down in the sacrum that goes to that part of the anatomy, and we stimulate the nerve. It's called interstim sacral neural stimulation, and I have some models we can talk about that. But that's a relatively new device that's made by the same company. They're called Medtronic. They make pacemakers, and it's really a pacemaker for the nerves and the muscle of the anus and the rectum. It's very interesting. They figured out in the early 90s that for people who had problems with bladder incontinence, where they were leaking urine because they couldn't control the bladder spasm and hold the urine back, they developed this device for urinary incontinence. And over the next decade or two, patients that had this implanted for urinary incontinence would come back and say, you know what? I used to have problems with fecal incontinence, and it's all better now. So it was subsequently studied and then approved by the FDA to be used for fecal incontinence. So now it's used for both. Same device, same location, works for both.
Wow. Is it common to have both urinary incontinence and fecal incontinence at the same time?
It is, especially in women over the age of 65.
Okay.
It's common in that population. Less common in young people, less common in men. Not impossible, but much less common. And you know, they've done surveys where they went out and they looked at different age groups. And as you can imagine, as you look at a higher age group, the incidence of fecal incontinence becomes higher. After the age of 65, between 65 and 85, some studies suggest that it's as high as 10%. All studies suggest that it's at least 5%. So 5 out of 100 people will have some issues with fecal incontinence.
Wow.
And if you add urinary incontinence on top of that, you can double those numbers. And then, like you're alluding to,
Wow.
there is actually overlap. There is actually overlap.
And I'm not surprised, really, to hear you say that it's more common in women. I would not be surprised if it were more common in women who had babies.
Correct. Correct.
That's hard on your body.
It is hard on your body, and you know, I don't have I didn't bring a graphic for this, but I think I can describe it. You know, the pelvis actually looks like a basketball hoop. It's a circle of bone. And all of the pelvic anatomy is suspended just like the net on a basketball hoop. And as we get older, the net stretches. And women that have had babies, the net stretches even more. And what happens with that is it puts pressure and tension on the nerves. It also changes the angles of things. It turns out that angles are very important in that part of the anatomy.
Oh, interesting.
Part of what occurs when you urinate, and especially when you defecate, is that muscles relax and they turn a pipe that's bent, kind of like a hose that's kinked, it straightens it out. And it allows stuff to pass. So when all of that stuff begins to sag, if you will, and relax, pelvic relaxation is what we call it, the angles start to change. And you run into problems both with uncontrolled leaking, but you can also run into problems where it's hard to defecate, for example, or hard to urinate. So again, it's a complicated area of human anatomy.
We've talked about some of the treatment options that are available. I want to stress again, after hearing that last caller, if you're having a problem in this area and you don't want to talk about it, you really should, because again, like you said, people don't necessarily die from this, but if it's something that's impacting your daily life, there are treatment options available. It sounds like there's some pretty good things, and you talked briefly about medications. Let's talk about what some of the medications do. And you said kind of keeping them on the cusp of constipation is the biggest thing, but let's talk about that in a little bit more detail, because if people think if it's as easy as going in and potentially taking medication, maybe they're more willing to go.
Yeah, absolutely. No, you know, I think in general, I think people ought to feel comfortable talking about uncomfortable things to people that talk about uncomfortable things all day long.
All the time,
right? I mean, you know, for us, it's very easy to talk about these things.
Right.
But getting to your question, some of the medicines that we use, as I mentioned, actually try to simply constipate the person, make the stool more solid, especially if it's somebody who is leaking liquid. Okay, they may lack the ability to sense that it's actually liquid there. So what we do is we try to solidify the stool, and I'll give you an example. Fiber. okay? Something like Metamucil or Citracel. I like to use the analogy, fiber is like taking a kitchen sponge and cutting it into a bunch of little pieces and eating it. So what it does is it mixes with the stool and it acts like a sponge. So it keeps it soft because it holds water, but it also prevents stuff, liquid, from leaking out of the sponge. And simply by changing the consistency of the stool, it gives the rectum and that part of the body the ability to sense what's going on and do a better job controlling it, okay? And that's not even really constipating. Now, we have medicines that are constipating. We literally will try to constipate somebody. There's also a broad category of medicines that are called the anticholinergics. And there's several on the market. They've been around for a long time. They're inexpensive. Most of them are generic. And what they do is they inhibit spasm or contraction. Some of them you'll see on TV will be advertised a lot for overactive bladder or OAB. What they do is they prevent the spasm of the bladder. We use them to prevent the spasm or contraction, uncontrollable, overly exuberant, or inappropriate contraction. When you eat a meal, the colon contracts. There's a reflex, just like when you hit your knee and your leg goes up, called the patellar reflex. This is called the gastrocolic reflex, gastro-stomach colon colic. So when you eat a meal, your colon contracts. You'll talk to older people at a nursing home that'll say, as long as I have my toast and coffee in the morning, I can then go have a bowel movement. They're taking advantage of that reflex. Well, in some people, like the caller that called in, it's exaggerated. And again, they don't have any control over that. That's that part of the nervous system that we don't control. So they go and they eat lunch, and within 30 minutes sometimes, when they're in a meeting after lunch, they have to leave the meeting and go to the bathroom because their colon is sitting there contracting with vigor to the point that they can't control it. So we have these medicines called anticholinergics that actually blunt that. They don't make it go away, but they bring it down to a normal level so the person doesn't have an amplified gastrocolic reflex, if that makes sense.
Yeah, it does. It really does. It's time for us to take another break. We've got an awful lot more to talk about when we come back, and we will be back in just a minute with more health talk.
It's impossible to replace anybody that you love. She was my great role model, my Grandma Keaton. It was pretty much of a shock for us when she got colon cancer. None of us were prepared for that. Here's the deal, and this is the bottom line here. Colorectal cancer is the second leading cancer killer of men and women over the age of 50. And you know what? This is one that you can prevent. Just get screened, okay? I know how precious life is right now. We can all do this. You can do it, I can do it. If I can do it, you can do it, okay? How's that for a deal?
Our weight, it's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me is Dr. Rick Newman. He is a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. Tonight's topic is one that we haven't done before. It's one that I think there's a lot of interest in, judging by some of the questions that I was given during the break. But I think that it's one that not a lot of people are wanting to talk about too much. I will give you the phone number again, and if you have any questions or comments, feel free to give us a call. If you want us to answer your question on the air, we would be more than happy to do that. If not, leave the question with the ones who answer the phone, and they will make sure that we get it during our next break, and we can try and get that question answered on the air a little bit later. Again, the number is 850-972-2642. If you have a question or a comment about fecal incontinence, it'd be a great time to call and maybe have that question answered for you. Before the break, we were talking about some of the different treatment options that were available, some of the medications that were available. I know that you have some pictures, some graphics that we brought. I don't know if you want to go there first.
Yeah, we can do that.
Let's do that. So we have a graphic of normal defecation, I think. So there it is.
So if you look at the picture that is on the left where it says at rest, this is some of the stuff that I was talking about with the angles. So there's actually a muscle that looks like a slingshot that attaches to your front pelvis bone, and it wraps around the back of the rectum. And when you're sitting there, as we are now talking, that muscle is tight and it's pulling the rectum off to the side to create an angle there. And that's one of those things that angle begins to diminish as the pelvis and all those muscles begin to stretch and sag. Now, if you look at the picture on the right where it says straining to defecate, what happens, you'll notice two things. If you look at the two red structures, those are the muscles. So one of them is the muscle that we were just talking about called the sling. We call it the sling sometimes, the rectal sling. Down at the bottom is the anal sphincter, and what you'll see is the sling relaxes and the anal sphincter relaxes. And that angle goes away and the rectum becomes a straight shot pipe, and it allows it to empty when the anal sphincter opens up. So that's just kind of, I wanted to show this picture because it shows, probably most of the viewers haven't seen this before and have probably never heard of the muscle called the puborectalis or the rectal sling. But it's very, very important, and it's one of the causes of the issue you were talking about is as women get older, commonly because of the anatomy of their pelvis, and especially if they've had children in that area, pushing and tugging on things.
Well, and it really does point out you can really see very well the angle is so important, that's what kind of helps keep everything in place.
And we actually have a test that looks at this. It's one of those tests I didn't want to talk about on live television, but probably everybody's heard about a barium enema. Well, we have a test that's done where it's kind of like a barium enema, except the barium is not put all the way up into the colon. It's just put into the area that you see here, which is the rectum and the bottom of the sigmoid colon. And then we actually have the person sit on a toilet bowl while there's an X-ray video camera that actually watches this whole thing occur to try to figure out. And again, the point is not to go into great detail other than to say we have a lot of technology that we can use to really try to figure out what's going on with a person and how best to try to address the problem.
And that's the most important thing, is figuring out what the problem is. Once you know what the problem is, then you can treat it.
Absolutely.
So we've had some questions that came in before the break. I want to get to those. One person called in and said that she has an aging parent and her father is 87. He's having problems now with stool seepage, and she was wondering if that's just a problem of aging. It hadn't been a problem before. Is it just a problem with aging, or could there be other causes?
That's a good question. So I think we tend to blame a lot of things on aging. Why? Because they are seen more common as people get older. But there are a lot of misconceptions about what's normal and what is abnormal. Because if you go and you poll 100 people over the age of 80, most of those people do not have this problem. Okay? So therefore, it's not, yes, it is more common in older people, but it's not necessarily normal. And we don't like to ignore older people's symptoms. Older people, if there's any way that we can help them, we do. And this is something that we may be able to. Now, we typically wouldn't recommend an operation in a 90-year-old woman that has a sphincter tear from her childbirth at the age of 22, but we definitely try to do more conservative things to help that person. So I think there's a difference between saying that something is part of the aging process and it's more common in older people.
It's a good distinction. Very good distinction. So it's definitely something that they should probably address with their physician, and then potentially, if it's something that's a problem, potentially there are treatment options available that could be as easy as medication.
Absolutely.
So definitely something that you should check on.
Absolutely.
I want to get into a question about diet and whether or not diet plays a role in any of this. And we got a question that is a perfect segue. They said that they had just tuned in, and what can you do to treat the problem? Is there a way to change the diet, potentially not eat rich or greasy foods? Is there something that you do eat or you should avoid eating if you are having this problem? The caller said that they don't have the problem very often, but it seems as if there are certain foods that cause it to be more urgent and potentially have accidents.
Yep. So what we'll hear people say frequently is and I think the caller even mentioned this, is that they eat something and it quote unquote goes right through them.
Yes.
Okay? Now, a little bit of basic GI physiology. When we eat food, it actually sits in our stomach for about 3 hours. Now, some of it begins to empty very early on after you swallow it, but the entire meal takes about 3 hours to empty. But what happens is you have that gastrocolic reflex. So the stool that is from yesterday or the day before, that's sitting down in the rectum, gets pushed out inappropriately. So the perception is that you put something in your stomach and it's now coming out the other end. What actually is happening is that you're putting something in your stomach which is making the bottom of the GI tract, which by the way is about 20 feet down that garden hose, okay? Wow. So from mouth to the other end, the anus, is about 22 feet long, okay?
Wow.
And it takes a while for things to get down to the other end. It varies. In some people it can be as quickly as 3 hours, 4 hours. That's unusual, okay? Most of the time things are hanging out in the colon for at least a day. So what you're pooping today is most of the time from yesterday or the day before. And for those of you at home, you can try this at home, is one day eat a half a can of corn and then check your stool and see how long it takes.
I call those tracers.
That's right. And we have a scientific test that costs a lot more than doing that, actually, called a SITS marker study. It's a little bit more sophisticated, but not much more sophisticated than that.
You can tell when you're changing diapers.
That's right.
Corn tracers.
That's right. And so you can actually measure in you. Now, there are certain foods, getting back to the question, that what they do, and it's typically fatty food, that when you eat fatty food, in a lot of people, it stimulates the colon, again, that gastrocolic reflex. It stimulates the colon with vigor. And so, like a lot of things with diet, there is no single diet that we can say, this is what you need to do for this particular problem. But a little bit of common sense goes a long way. You know, if the person discovers on their own that every time they eat fatty food or they go to this particular restaurant, it stimulates the GI tract to move very, very quickly, well, then they probably shouldn't do that. Or they have to decide if the food is worth it.
That's right.
That's the important question.
Now, I know that some people that have gluten intolerance, they seem to say sometimes too, as soon as they eat something that's gluten-y or something like that, they have to go to the bathroom right away, or it could cause 2 or 3 days of diarrhea, something like that. Is there a correlation between gluten sensitivity, gluten intolerance, and the urgency which could potentially lead to the fecal incontinence?
Yeah, I mean, we could almost do a whole show on gluten, right? I mean, that's a complicated topic. But I think that suffice it to say that what I just mentioned for fat is true for gluten in some people.
Okay.
You know, and it's true for milk in some people, and it's true for raw fruits and vegetables in some people. So everybody's different. Okay, and in some people, when they put something in their stomach, it makes the GI tract go crazy, and what it's going to try to do is push stuff out the other end. Okay, and if it's done with enthusiasm and at an amplitude that you can't control, there are 2 things that are going to happen. Well, 3. You can hold it back. You can run to the bathroom and make it, or you can run to the bathroom and not make it. But that's what's going to happen under that circumstance. And again, you know, we have medications that can help control that.
If someone is having a problem like that on a relatively regular basis, a few times, 3, 4, 5 times a month, would a food journal be helpful in trying to figure out what those triggers might be?
Yes and no. You know, for the most part, if you want to get really, really frustrated, keep a food journal. You know, I mean, it'll drive you crazy.
Yes.
And the problem is that there are so many molecules that we put in our mouths in one simple meal to try to figure out what it is. Now, some things we have figured out. You know, gluten in celiac disease. We've nailed that. We know what causes celiac. But most things are not like that. And it's very, very variable. And so it really requires, and the same is true, I hate to mention the term because again, you could do a whole other talk on food allergies. But ultimately, whether you do testing or not for food allergies, it comes down to making a definitive cause and effect relationship between what you're doing and the effect that occurs. And it has to happen consistently and reliably before you can draw any conclusions. And that's really, really difficult.
Sure.
Right? Very, very difficult to do.
Sure. It is amazingly time for our last break. If you have a question or a comment, we would love to hear from you. We have one more segment of the program left. The number is 850-972-2642. Give us a call, give us your question. We'll be right back with more Health Talk.
Our weight, it's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
El cine nos entretiene, pero esto no es la vida real. Lo que sí es real es que el cáncer colorectal es la segunda causa de muerte por cáncer entre hombres y mujeres. Los pólipos que lo causan pueden detectarse y eliminarse antes de que se convierten en cáncer. Pero tú lo puedes prevenir. Hágase un examen para detectar el cáncer colorectal. Yo lo hice. Podría salvar su vida.
Si usted es mayor de 50 años, hágase el examen de detección.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me is Dr. Rick Newman, and tonight's topic is fecal incontinence. And it's been a popular topic, although we have not gotten a whole lot of calls on the air. We've had quite a few calls that have come in to the control room, and they have been bringing them to us. We still have a model we want to talk about. We want to talk about some other things and show you some visuals of a few of these things, but this is an interesting question. Someone called in and said he doesn't have a problem with incontinence when he's awake, but when he is sleeping, he has a tendency to have some leakage. And, you know, during the day, he can control it. At night when he's sleeping, he can't always. What to do? I think it's a good question.
It's a really good question, and actually it's a very good lead into the next segment that we're going to talk about, which is a relatively new device that we use for fecal incontinence. This person would probably be a very, very good candidate for that procedure. You know, while they're sleeping, they obviously don't have much control of what's going on with your bodily functions, right? Our legs jerk, we drool. You know, we do things at night that we don't have a lot of control over. And you know, you could make, one of the thoughts that comes to my mind is boy, wouldn't it be much worse to have this occur during the daytime at night? But that's not completely true, because, you know, one of the things that'll happen is you can actually end up with sort of a diaper rash. You know, again, an area that we don't really like to talk about much, but can be super, super debilitating and uncomfortable. So, you know, that area of the human body is 37 degrees Celsius. It's moist. There's bacteria that live in our gut. It's a perfect setup for a skin infection, or what you see in your babies, right?
Yes.
Is a diaper rash when they're sitting there with a soaking diaper on. As often as you can change it, they still tend to get a diaper rash. So this can be fairly debilitating. And again, we could try, and we would typically try some medications, usually before somebody goes, in this circumstance, before they go to bed at night, and try to constipate them a little bit to see if that helps. But this person would probably be a good candidate for the sacral neural stimulation, the interstim procedure, which is what we're doing, a relatively new procedure that's being done for fecal incontinence.
So let's talk about that in a little bit of detail. We have a model that you brought. Let's kind of talk about the model and what it shows, what it is, and
so this is just a model of the sacrum, and this is very good. What's on the screen right now is what I'd really like to show, and I'll point some stuff out with the model here. So what you see there is a small device in the right upper quadrant, or the right upper corner of the screen there, which is almost like a pacemaker. And like I mentioned before, it's made by the same company, Medtronic, that makes pacemakers. And what it is, it's about the size of a silver dollar, and it goes underneath the skin, and a very small wire goes into that little opening in the sacrum. Now keep in mind, the spinal cord is way above that. This is not the spinal cord. These are nerves that come out of the bottom of the spinal cord. And what this device does is it sends out an electric impulse that wakes the nerves up. And it's not just the nerves that make the sphincter muscle stronger, but it's the nerves that help with sensation. So what I tell my patients is that it really wakes everything up. It tries to make the nerves function like they did when we were much younger. They need to come up with a device like this that just plugs into our brain.
A lot of things.
We don't have
I
that.
know.
We don't have that yet.
I know.
But it wakes the nerves up, and so it works both in terms of making the nerves that control the muscles stronger, but it also helps with sensation. So the person senses, even at night when they're sleeping, the nerves that normally know don't relax the sphincter muscle. Something's there while you're sleeping. Remember, the internal anal sphincter is not under voluntary control.
Right.
It's a feedback loop that occurs without you thinking about it. In that person, that last caller, that's probably where the problem is. And what this device does is it wakes all of those nerves up. So what I brought is just a model similar to the picture that you see, but what I wanted to show, the top of the sacrum is actually removable, and everything that you see here, the spinal cord actually ends up here. This is the last lumbar vertebrae. And what you see down here, although it shows it as a solid piece of plastic, they're actually individual nerves that come out. And where we put this little device, and I have a sample of the device, I'll hold it up so everybody can see what size we're talking about. So this is actually the neural stimulator called interstim. And what I have here is one of the wires that we put through there, and I'll explain the procedure in a little bit more detail, but I at least wanted to show the model. So here's one of the little wires.
It's so small.
It's very, very, very small. Okay?
It's just bigger than a hair, it looks like.
It's very, very small. The one there are two steps to this procedure. What we do is we bring the person to the endoscopy center. They're awake, although we like to use a mild sedative by mouth, a single pill an hour before they arrive. It kind of relaxes the person. And we numb up an area, which is sort of at the top of your buttocks, over the sacrum. We numb it up with some lidocaine. We put a small needle down into this little opening right down here. And through the needle, we put the little wire. And the wire, it's going into the skin about 1/2 inch to 1 inch. The wire comes out of the skin. We plug it into the little stimulator, and it gets taped to the person's back. We cover the small of their back with tape. They go home for a week. There's a little remote control that's super simple. You could actually, I was going to say you could teach a 5-year-old. They'd be probably better at it than we are.
Probably
yeah,
so.
yeah. You can teach us with this very, very simple device that raises the amount of electricity up and down. And the person wears this thing on their back for a week, and they keep a diary. And most of then we bring them back to the office and we just simply remove it, and then I see them in the office and follow up. And I can usually tell when I walk in the door and see that person. They're usually smiling from ear to ear, or commonly they are. The test is positive in about 75% of the patients that we do. It's super, super successful. The temporary wire that I showed here, this very, very small one, is not as effective as the more permanent device that's put in for a lot of reasons. So when somebody comes back and they said the number of episodes I had were reduced in half, we jump for joy. That's considered success, because when you do the permanent one, which is the same device but it goes under the skin and the battery lasts for about 5 to 7 years, the results and the success rate in that person is better than 90%.
Wow.
It's one of the happiest. So when I mentioned earlier in the first segment that when somebody comes in and says, I'm here for fecal incontinence, we used to sit there and go, oh, great.
Yeah.
Because there wasn't a whole, but we weren't very successful. Now when somebody comes to us with fecal incontinence, we actually have something that we can offer them that's hugely successful, life-changing.
Absolutely.
You know, life-changing.
If it's something that's been keeping them home because they aren't able to go out in public because they're worried or whatever, that is something that absolutely could make a difference in their everyday life.
I call it the pacemaker of the butt.
No,
I don't actually call it. I just made that up.
It works though. It's
no, but it is, and so it's turned into, this problem is turned into one of frustration and disappointment into something that is actually very, very encouraging and successful. So yeah, it's interesting. We've come a long way. It's a good example of micro technology, you know, affecting human physiology with huge implications and huge benefits.
Absolutely, and I think the most important thing, if people get something from this program, is if you are having this problem, talk to your doctor about it, because there are treatment options available. There are certainly things that you can do. It may be as simple as medication. It may be something that's a little bit more technological, but there are certainly things you can do. And that wraps us up for this evening. Thank you all so much for being here, Dr. Newman. Thank you. It's been great. We've learned a lot, and we hope you join us again for more Health Talk.
Thank you.